Good afternoon, dear colleagues. It's a great privilege for me to present for you today. Thank you to organizers of APASO for this opportunity. And today, title of my presentation is When the Virus Doesn't Retreat, HCV Drug Resistance in a Real Case Report. I would like to begin by briefly outline of some key points of hepatitis elimination program in Uzbekistan. Nationwide mass screening began in 2018, and currently around 500,000 people every year tested on viral hepatitis markers. According to these screenings, the prevalence of anti-HCV among adults is 4.3 and HCV RNA is 1.9. Also, Uzbekistan received from Arab Republic of Egypt 400,000 of units of sofosbuvir and daclofenacin, and at the date, more than 51,000 patients complete treatment free of charge. I would like also emphasize that since 2018, DIA have been available. The issue of drug resistance has become increasingly relevant over the time. The main contribution factors of development of drug resistance include poor adherence to therapy, lack of scientific research, quality of DAs, generics, and national evolution of the virus. With this point in the mind, let us turn to the clinical case report. 54 years old male, asymptomatic, without co-infection with other hepatotropic viruses or HIV, no smoker, without alcohol consumption, but with overweight and BMI about 29, was diagnosed during routine check-up in private clinic for first time in 2010. And I will shortly explain timeline of his visits over 14 years of observation. In 2010, when first time diagnosed HCV, hepatologist recommended him PEG interferon plus ribavirin therapy. But physician also explained about side effects, very acute side effects to this patient, and patient declined the therapy. The lack of symptoms and underestimation of long-term risks significantly influences to his decision. This reflects a common misreception for patient. Is a treatment really necessary when symptoms are absent? In 2015, he back to private clinic again. He has no significant symptoms, but his family patient's insistence for his consulting with hepatologist. And hepatologist recommended him 24-week regimen, sofosbuvir plus daclofenacin plus ribavirin. But cost of this treatment was very high, and in this time it was very popular in Uzbekistan to buy DA through social media, through some groups in Facebook, for example. And he independently purchased generic DA from India through private contacts in social media. And he reported good adherence, but could be sure about quality, storage, and authenticity of these generics. The high cost of DAA leads many patients to purchase treatment independently, which exposes them to the risk of counterfeit and substandard drugs. In 2018, was first DAA therapy failure. PCR test for HCV RNK was positive. And it was in January, and in March was a second attempt to therapy, but this time it was official DAA. It was sofosbuvir, sofosbuvir, and velpatasvir. This medication had been officially imported into the country and were dispensed by prescription. However, according to the patient, he missed 1 or 2 doses of the medication, and after completing the treatment course, he did not undergo follow-up testing for HCV. According to patient, using the official medication and lack of symptoms gave him confidence in success of the treatment, and he did not go for follow-up visit. So official DA not guaranteed SVR. In 2018, it was his first visit to Research Institute of Virology. He reported about first symptoms, discomfort and upper right quadrant and fatigue. And during his anamnesis, doctor think about HCV drug resistance and recommend him to make this testing, RAS testing. But unfortunately, in Uzbekistan, at the date was no RAS testing, and doctor recommend him went to Belarus as a closest location with RAS testing. And in results, in resistance profile, detected NS5A substitution, 33M and 93H. And for NS3 and NS5B, no RAS detected. Recommended therapies included NS3 inhibitors, but at the time, estimated cost for NS3 inhibitors course therapy was about $30,000 in Uzbekistan, and patient was followed up from observation because of high cost of medication. In 2010, patients still didn't visit doctor because of high cost of treatment. But from some acquaintances, he learned about new generic DA, and he bought it independently with commercial name Virvel. It's sofosbuvir plus velpatasvir, but patient purchase this medication without medical supervision. And unfortunately, he was repeat previously failed drug with NS5A inhibitor velpatasvir. In 2023, patient present more severe symptoms and visit again Research Institute of Virology. In laboratory findings, HCV RNA viral load was very high, genotype 1b. In FibroScan, cirrhosis child PUA class, high level of ILT and IST. And doctors repeat RAS testing in Research Institute of Virology. And RAS testing confirmed persistent mutations, persistent substitutions in NS5A regions, 31V and 93H. And also new one substitution, 170I in NS3. Recommended regimen was glecaprevir plus pibrentasvir plus sofosbuvir for 16 weeks. Patient paid for DAs by himself. It cost was $2,854, and patient completed course fully, and finally SVR achieved. At this point, I would like to briefly present our efforts in developing HCV drug-resistant testing in Uzbekistan. The sequencing department at RAV, established in 2007, has long been engaged in molecular epidemiology and public health research, including genotyping and vaccine effectiveness studies for rotavirus and influenza, drug-resistant surveillance for HIV, and monitoring genotypes of hepatitis, monitoring of enteric pathogens and SARS-CoV-2, and we are equipped with 2 platforms and for sequencing. And this year we will get a new one, Illumina. And to date, we have deposited over 1,000 sequences in GenBank and GSAID. And recently, we began also metagenomic sequencing experiments. Our protocol for HCV drug resistance testing, we developed in collaboration with Hiroshima University. And I would like to say many thanks to Vice President of Hiroshima University, Professor Junko Tanaka. And also, we are grateful for the CDC Uzbekistan for their support with the bioinformatic components. We understand the need for protocol development arose the increasing patient request for HCV-DR testing. From 2016 to 2022, 16 patients requested testing in RAV. But at the time, we recommended them make testing abroad because we have no such protocol. But in 2022, situation is changed. A major milestone was presidential decree number 243, which included support for scientific research into HCV drug resistance testing to aid national elimination efforts. And due to high variability of HCV genome, especially NS5A and NS5B, only in-house tests are currently used globally. There are no commercial kits. Also, developing of protocol is genotype specific, and we check genotype distribution in Uzbekistan. And it was like in previous session, professor from Kazakhstan explained about situation in Kazakhstan. In Uzbekistan, the same. In general population, 1B genotype dominance, but in non-responders, dominance genotype 3A. And for last 3 years, many patients received the drug-resistant result tests, and you can see how it looks, and list by genotypes of substitution. And we have now full list for 1B genotype, but for 3A, we have some troubles with protocol development because of very high variability of NS5A in 3R genotype. Let's return to our patient. Yesterday, Professor Wedemeyer from Germany emphasized the importance of monitoring even after SVR. The patient came for follow-up visit in 2024, and SVR confirmed results for HCV RNA was negative. And hepatologists recommended check-up for HCC. And AFP level was high, with high suspension for malignancy, and NCT was noted in right lobe. And we recommended go to oncology center. You can see node images in contrast CT. Treating HCV is a race against time. With this case, not regular. This patient is very unique, but especially this case illustrates the complex challenges of managing chronic HCV in resource-limited settings. Summarize, we must make more efforts for patient education, for information patient. Some barriers have already been resolved through governmental support. However, the next critical step is to organize sustainable funding mechanism for second-line therapy patients. In previous session, Kazakhstan reported about access to the second line by government budget, but in Uzbekistan we still have no sustainable funding mechanism for second line therapy, and there is little value in drug resistant testing if patients have no money to purchase necessary medications. As mentioned earlier on first slide, over 51,000 patients have been treated in Uzbekistan at the time. With 98-99% efficacy, at least 500 patients currently need resistant testing, and most of them will need second-line treatment. Also, in few years, the problem of resistant HCV strains may become more serious due to the fact that such patients can participate in the epidemic process and spread resistant strains. Let me close with these words. This case is not just about one patient. This highlights systemic challenges and reveals an opportunity to improve care pathways for many more. Thank you for your attention.